All right, welcome guys. Dr. Miller here, also known as Professor, some circles known as Kingfish. Unfortunately, due to statutes of limitations, I can't tell that story for about 5 more years. But anyways, come to you to talk about documentation SOAP notes. And I thought the best way to do this would be actually to looking at a WebPT note from initial evaluation and just kind of going through, but really hitting on the idea of the assessment and what the assessment is and how all these things relate to one another. So, without further ado, just some key points. I'm going to kind of scroll down and kind of hit some of those things that you absolutely need in a SOAP note initial evaluation. Of course, every place is a little bit different, but for the most part, these are going to get your check marks that you need to do. Most importantly, the check marks that's needed for Medicare as well. So going down, of course, you need the date. From an ICD-10 code, every place can be a little bit different. You always want some type of physical therapy diagnosis, but also bringing in a little bit of that medical diagnosis as well. Some places want you to stay away from medical diagnosis, but actually some insurances require that as well. So going further down, treatment side is important. Some issues, when did it happen, were they hospitalized, etc. And then we get down into the nitty-gritty a little bit. First, what is going on with this patient? Who is this patient? What was the mechanism of injury, right? So as you see, Carlos is a 45-year-old male, and talking pretty much this is the medical history of what's going on. But I don't think we need any emojis. But when we then go down into his complaint, why are you here? Or in this case, why am I, the therapist, going into this patient's room? That is where this primary concern and chief complaint would be. If this is an outpatient orthopedic place, this would be my AGs and EASes and 24-hour pattern, etc. Here we're doing an acute care, but that is generally where you want to put most of it. So honestly, I always start my evaluations with, so tell me your story. I'm going to put the word vomit of the patient here, and here's where I'm going to dive deep into that patient. Prior level of function, you need to ask it, you need to note it, any issues before this incident, etc. Make note of that, and then we can get more into those current functional limitations. Depending on, what you're looking at here, I noted more of the neuro and cognitive issues. So that way you could possibly make a sense of some of the holes that will be in my note if the patient has difficulty speaking, like certain aphasia, especially like expressive aphasia, or attention issues. Further going down, absolutely when dictated pain occurs, any type of social history, etc., job, all of those things. What does the patient's house look like? What are they going to go home to? Do they have a history of falls? How is their cognition, etc., right? What's their current diet? I know that seems kind of crazy to put, but why? It might make some sense looking at their medical history or some issues going along. So again, putting those little nuances can be there. Adding any type of pertinent medical history that needs to be deftly expressed, any diagnostics. Going down into their medical history, we won't necessarily dive right now what's low, moderate, and high. You can definitely think about WebPT as it does give you some highlights, but there is a criteria that really hits all 3 of these factors on which one they're going to be. Generally, most people will hit moderate with a few in high and a few in low, but it is something that we need to be rating because it's our argument how complex they are, thus how much of a level of care that they possibly need. Again, more information about the patient, current medications, and also they're just subjective goals, right? We're check mark that one. Again, this is very general and what the patient gives, and this might be in the chart, etc. But from a just straight up journal basis, these are the things that you would be looking for to add in a subjective evaluation into the S part of your SOAP note. Then we're going to go objective. Cool thing about WebPT, you can add some tests, etc. You can add some things on here like general, vestibular, pelvic health, speech, etc. On this one, I just put general for the patient. Inspect the patient. Just what do you see? What are some things you gain from it? We always want to do some type of functional outcome for that patient, things that are meaningful to that patient. And also describe what you were required to do so that way you can measure success, right? So I might have some timed up and go, and there's 30 seconds, that's a big deal, right? That's significantly high. But if he can maybe get there where he does not need any hand assist, okay, we're making positive gains, right? Filling their gait, it's utterly crucial if you put that you're going to be treating gait for the patient, that you actually have their gait measured. That's a Medicare requirement. What are they used for, etc. And then you want to put in the range of motion that is pertinent to them, right? So as we'll see later, this patient has shoulder issues, so we measured the shoulder, compared it to the other side, and then kind of going down. Again, this is not, you don't have to test every single one per se, but what is important to this patient and that you can focus on now. If they're going more into an outpatient setting or a rehab, they're going to be there a long time. You can go into this a little bit more, just depending on where you're at, what are your goals, what are you looking to do with this patient at this time. But you need to have some important things in there, especially if you're arguing a treat. Strength testing, absolutely appropriate for this patient, going all the way down to the hand, because this is a stroke patient we're talking about. What are the reflexes like, and also if there's any special tests, or just even observations that you can put. Here I'll put a positive sulcus, very common after stroke patients. This also will go further into our assessment, etc. So as you see, we got some strength issues, some atrophy issues, range of motion issues, and also some fall risks, etc. Taking the subjective and then taking the objective, combining those and saying, hey, this is what the patient's telling me, this is what I'm seeing, and when they come together is that beautiful collision to what I am going to be able to help that person, right? That's your assessment. What is this patient? So, you can see their age, what their medical diagnosis is. Then what are they demonstrating? What are the impairments? What are, so patient has this and this is what I'm seeing. Your impairments, your range of motion, your strength, reflexes, tone, etc. And then what does that mean, right? I have lack of shoulder range of motion. There's plenty of people that have zero limitations in life with 150 degrees of shoulder range of motion, right? There is plenty of people in this life that have zero functional limitations and they're at a 4- with their shoulder. What we need to show here is because of that 4-, so that reduced range of motion or that reduced tone, there have functional limitations in insert the list, right? So for this patient, and this needs to match subjectively. They have problems bathing, grooming, dressing, sleeping, independence, eating, etc., right? So you're matching what the patient said to the impairments, showing this is what they're missing, this is what I'm going to do to get that patient better. And if you think about it, it really is an A, what the patient said, B, the impairments you measured, equals C, what you're going to do about it. Impairments, this is what I measure, it's leading to this functional loss, this is how I'm going to improve it, right? And that's what you get here. Again, going back to the presentation with the patient, and then finally, what did you educate on? That's a cool thing that WebPT does here is, and this isn't every single thing, but it might want to be that line of education that is going to follow that patient through. So for here, you see that I said, they perform safely and were educated on the HEP, constantly vigilant of the right upper extremity, also not performing transfers without someone present, and also family members were educated as well. This area is a good CYOA area for you. If you don't know what that means, ask your parents. But this area really says, hey, I did teach the patient these things, and you need to document that you did that, right? Also down check marks them here, and you can even further add some goals list. I didn't give much thought into these goals, and typically you'd want to expand them out a little bit more. It's really dependent on, what is the patient's hopes and dreams, but also what do you feel the patient needs to be able to, either get to the next place of care. For instance, transferring out of bed into chair, transferring into car upon discharge. Those are very specific to possibly a hospital, but those would not be appropriate necessarily for an outpatient unless they're very low level. Again, put them short term, 1 week. We want to hit them well, and get them on their way, right? All right, so finally, what's the plan, Stan? Again, this can be anything, right? I put 2 times a week for 4 weeks, but you could easily go in here and say, man, we're going to see them 4 times a week. It's a hospital. Cool, awesome. 4 times a week for, 2 weeks. Typically, if it's going to be a hospital, it's going to be like this, right? Or you hope to see them again. But you really do want to really put some thought and care into this, because this is your thought of like, hey, if I get them for this long, I think we can go here. So I do need to see them 4 times a week this week, or I do need to see them, 2 times a week for 4 weeks, etc. Just depends on what you're trying to do. But ultimately, you are trying to define what you would like to do or what you think is appropriate. I would argue that generally you don't want to make a plan of care beyond a month. Depending on different insurances you can, but that month actually holds you to be true, because you should be writing a progress note or reevaluation within 30 days. So, 2 times a week for 4 weeks, yada yada, you want to make sure it is within a month time. Finally, and these are not check mark, I don't know why, but here's the procedures you're going to do, and any and everything that you can think that is going to be appropriate for this patient, you want to absolutely check mark here. Reason being is, for a lot of insurances, if you don't check mark it, say like, this patient is very appropriate for electrical stim, but say I didn't check mark this, and you don't even necessarily need to go into these, but say I left this blank and I do like neuromuscular reeducation with a Russian, I can't necessarily bill for that because I didn't click it, and insurances won't approve it. Same thing with modalities, neuromuscular reed, manual therapy, all of those things. So I always tell people, if you think you're going to do it, absolutely check it. Just make sure it makes sense. If you say that they might do aquatic therapy and you are, zero access to a pool, that's probably not the best idea. So awesome. Billing, not important, because, this is just working on documentation skills. But those are the things that you want to add to the note. Again, documentation, it does not have to be this extremely lengthy process where you're spending 30 minutes on a note, etc. Evals, you should knock out in close to 10 minutes. Daily notes, it can be anywhere from 3 to 5 minutes. Documenting as you go is a skill, and it's crucial in this day and time. The key thing that you want to make sure that you do is that you want to cover yourself, because that's significantly important. You want to make sure that you are communicating well between doctors, yourself, other therapists that are going to come. And then finally, you want to make sure that you're supporting your skilled care with this documentation. The reason that is so important is because not only is you're worth it, right? You're a physical therapist, you're amazing. You are a skilled level of service, but also you're arguing to insurance companies of why they should pay you. And here's the thing, if they don't pay you, if they say, no, that wasn't warranted, who do you think is going to be stuck with the bill, right? Or heaven forbid, they're not going to necessarily get visits or further authorizations because our notes are lacking. Oftentimes where I see that happen is because the initial eval was not thorough enough that the progress notes and re-evals could not add upon that. So it's telling the story with a terrible beginning. And we all know those stories don't really go well, right? So this is the way to start off the story and truly get us an idea of here's where the patient is, and most importantly, here's our plan to get them to where we want them to be down the road. Thank you so much. I really hope this was helpful. Please reach out if you have any questions. Thank you.